Okay, can we get started? We're so very happy that we got the opportunity to arrange a lecture here in collaboration with you. People from Amgen, Claes and myself, Ola Jelin. We also have the colleague in the back, Mikael Hansson. We have a special guest today, and he is the medical director of clinical research at the university in Frankfurt, mainly within dermatology. Some few things that people don't know about this guy is that he is a football supporter for the Frankfurt football team.
Yes.
Also, he's planning a vacation trip to Sweden next summer. So, yeah, he's here today to learn more about Sweden as well, not only lecturing. And the topic is to tailor the psoriasis treatments that we have today to the patients that can get the most benefit of them. Treatments in general and apremilast also in particular. We are streaming the lecture. That's why we have some cameras in the back. So we might get some questions afterwards from online. And you're all welcome to ask questions, but we prefer to get them after the lecture. Did I forget to mention it? Yes, and the name of our lecturer is Dr. Andreas Pinter. So give him a warm welcome, please. And last but not least, please sign the papers with your name so that we know you attended the lecture. And if you want to have it digitally afterwards, we can send it. And then you just type your email address there as well. Thank you. And warm welcome, Andreas.
Thank you very much. So again, thank you very much for that kind introduction. And normally I don't get applause before I start my lecture, sometimes later on. So that's why I'm very happy and very glad to be here. It's not my first time in Gothenburg. I have been here a couple of years ago with some friends for a weekend, and I really enjoyed the time, just a couple of days here. So I'm happy to be here again, but now in another position. I just want to introduce you to maybe some new data about apremilast, about some kind of medication we use since a couple of years in the field of dermatology, especially in psoriasis. And I hope I can show you also some new data, some scientific data regarding that kind of medication, that kind of treatment. So these are my disclosures. You see there are a lot of pharmaceutical industries here. Because I'm running a clinical trial department, we're doing a lot of studies, a lot of clinical trials, and these are our collaborators, so starting from phase 1 to phase 4, mainly in the field of inflammatory skin diseases like psoriasis. There have been a lot of clinical trials in the past. Now atopic dermatitis is in the focus. There are also some new ideas, some new inventions how to treat atopic dermatitis in future, and that's why the list is quite long. I want to introduce me a little bit more. This is Frankfurt. This is my hometown. In the morning I started here to work, and my flight was at 10:30, something like that, so it's a small world now. This is how it looks like, and we have a lot of skyscrapers, and if you climb up one of these skyscrapers, you have a nice view about the area, the city of Frankfurt. It's about 700,000 people living there actually. And if you look here on the right, maybe most of you know that place. What is it? It's the airport of Frankfurt. Yeah? Okay, but it's not the same. So whenever you have some times to go into the city center, it's quite nice city center. Just do it. And this is the university hospital, the area of the university hospital. We are not the biggest and not the oldest one, but under the top 10 of the university clinics in Germany. And this is not my department, but the department where I'm working in, the Department of Dermatology. And here in the basement, this is where I'm working more or less every day, and my team is working every day. And we have a specialized center for chronic inflammatory diseases, skin diseases. So we see a lot of patients with psoriasis, for example, atopic dermatitis, hidradenitis suppurativa, also a very interesting disease. And just to have a little introduction where I'm working every day. So what we see, and the focus now is on psoriasis, and I just You know all that cases, some severe forms of psoriasis that we see more or less every day. Some children with a glutate form of psoriasis, of course. Some special manifestations like a scalp psoriasis. These are all forms and facets of psoriasis we see more or less every day. And patients ask for help because you agree with that totally. Nobody is happy to have that kind of disease, stigmatization, and you have a bad quality of life and so on. Yeah. So when we talk about treatment decision, we need to ask, of course, first the patient. So what is the treatment goal of the patient, what he wants to have, what kind of treatment he wants to have, what are his wishes, and of course it should be easy, an easy regime, a good response, long-lasting response, if it happens, some kind of fast improvement, and at least no side effects. That would be the perfect kind of treatment. And I asked some patients, and if the tablets maybe taste like chocolate, that would be wonderful. It doesn't happen very often, but this is how patients see and the wishes of patients when we talk about any kind of treatment for psoriasis, example. But from the physician's perspective, from our perspective, it's quite different. Of course, we want to have the same options, the same results like here, but we have to be aware on other points, of course, like do we have an aspect on special manifestations? Did the medication I choose work also good for scalp psoriasis or nape psoriasis? Do we have a low effort? Sometimes it's important if you have some private practices, you don't want to spend too much time with your patient. Is it accepted by the health insurance companies? What about the price? What about the contraindications if patients take a lot more of medications? Can I combine it with methotrexate, with topical agents, anything like that? Anti-drug antibodies, and the acceptance of the patient, of course, it's very important. So the next slides, don't take it serious. This is what I not recommend. And I tell you later on why I show that kind of slides. So what we not recommend is, for example, this one. Do you know this? Some people do it when they travel in the south of Europe, some kind of fishes. But to be honest, this is nothing what we really just want to prescribe the patients, because that has also some possible side effects. Some mycosis can be transferred from one patient to another, and the fishes are really starving, so that's not very kind also to the fishes. That's why nothing we can recommend. The next thing is like this. Self-urine treatment. Some patients do that, really. Yeah, it helps a little, of course, because of the urea. It has some little anti-inflammatory effects. It has some effects on the scaling, but again, nothing we can recommend. And top one is that guy. You know, when patients have a disease, they look for some information. And what they do nowadays, they go to Google, they go to YouTube and anything like that. And when you put on YouTube only psoriasis, only that word, you find that guy in the first top 10 or top 15. Yeah? And you see here, he has obviously a psoriasis, and what he's doing, how he recommend his kind of treatment, he's doing this. He takes a knife and start to scratch all the flakes and the scales from the plaques. And this is what he recommend. Yeah? And people sometimes believe this. Yeah? Nobody told him about the Koebner phenomenon, because when he started in the legs, maybe it takes a day, and then he comes to the top of the body, and of course it is an activation of inflammation. And maybe someone told him, and this is his new way now. So he take a little pincet and just peel out the flakes. Yeah? Again, people sometimes follow this kind of recommendation. It's hard to believe for us, but they do. Okay? Yeah? And that's why we need to spread out the right kind of information. That's why we as a dermatologist are important, just to give the information what has a benefit and what has not a benefit when we talk about treatment of psoriasis. And we are the experts of that. Yeah? So This is a guideline for psoriasis treatment in Germany. We divide it between topical therapies and systemic therapies, and you see what we usually recommend. This is what we widely use, has some good effects. We don't recommend TAR anymore or retinoids anymore, or even laser therapy. That really doesn't work that well. So that's why steroids was combined with, for example, calcipotriol. And for the systemic therapies, you see here what kind of options we have. And to be honest, this is a luxury position. Actually, we can choose out of a lot of potential therapies. We're starting with conventional systemic therapies, cyclosporine, methotrexate, fumaric acid, also approved now in Sweden, phototherapy. We have here Premilast as a newer versions of systemic therapies, and the whole group of biologicals, different ways of mode of action, but all of this are some opportunities we can prescribe or we can offer our patients now. So the big question is now, what is a good patient for that or this kind of medication? So find the right patient profile for the options we have now. First of all, I want to show you that mode of action. I'm sure you'll be aware of that, how it works, but I just want to repeat it a little bit. We have now 4 TNF-alpha blockers. Certolizumab is the latest one, just had been approved, and TNF-alpha works quite early, quite late in the pathophysiology of psoriasis, so it works quite nice. It has some good effect on psoriasis arthritis. Our rheumatologist just prescribed this as a first-line systemic biological therapy. We have the IL-12 or IL-23 blockers. They act also quite early, so we can prevent the development. And when we block IL-23, for example, the IL-23 receptor is a kind of survival receptor for the Th17 cells. And the Th17 cells is a main cell which produce, that's why the name, for example, IL-17, one of the main inflammatory cytokines. So we can stop the production or the activity of the Th17 cells. We can also stop the main cytokine, IL-17A, when we bind it or block it directly, or we can also block the receptor of IL-17. It's bordalumab, for example. So one important point is we can block it very specialized. So we are not blocking the whole kind of pathophysiology ways or potential ways. We are blocking very specific, just one cytokine, and can have some effects on it. Compared to this, Premilast has also some effects, but not specific on one cell or one cytokine. We can inhibit all the related cells. For example, can produce also IL-17. It's not only the Th17 cells. And that's why we have a broader effect when we take, for example, such molecules like a Premilast on the dendritic cells, on the T cells, on the keratinocytes. This is one major point. So again, antibodies, for example, here in IL-17 antibodies, we can block specifically some cytokines. And of course, for example, we have some IL-23 left. IL-17 is reduced, and the result is we can reduce inflammation. That's quite okay. And we have the same effect here to reduce inflammation when we use a Premilast, but in another way, in another mode of action. And when we see here, this is, I just want to repeat it, I'm pretty sure you know it very well, how a Premilast or PDE4 inhibition works. So a molecule, a small molecule like a Premilast, it doesn't bind outside of the cell, it can enter into the cell, and what it do here is it blocks the PDE4 enzyme, and that's why cAMP is increased, and cAMP, kind of second messenger, has some other potential effects on the cell. For example, it can activate protein kinase A, and this is the result of this. Some transcription factors like NF-kappa B, you know it's a pro-inflammatory transcription factor. The activity is reduced, and some other transcription factors like anti-inflammatory, like CREP or CREP, for example, they are increased. And that's why we can change the pattern in different cells, T cells, keratinocytes, dendritic cells, monocytes, for example, from a pro-inflammatory pattern to an anti-inflammatory pattern. This is how it works. So now it comes to the patient profile. When we have, for example, a really severe form of psoriasis, like in that lady with a PASI close to 30, and you see this is a severe form, heavily infected or affected. When we use some biologicals, for example, and this is when we talk about treatment goals, when we want to have a quick relief with a high burden of disease, we can reduce the inflammation very nice. For example, here 3 months later with a biological agent, it works quite nice. We have some good effects, but again, we have also some good effects when we take the oral medications or newer oral medications like methotrexate or like apremilast. So here also in a patient profile, a patient with apremilast, usually when we in Germany use apremilast, we do it before we enter or before we start with biologicals. So there's one sentence, so best before biologicals, and this is what we really do. So when patients had some conventional systemic therapies like methotrexate, cyclosporine, sometimes retinoids, but I don't prescribe retinoids very often anymore, or fumaric acid, it's widely prescribed because we have some long-lasting experience with fumaric acid. And if the patient fail, for example, on that kind of medication, in Germany we have a second-line label, that would be a good option, for example, like on medications like apremilast. And I'll show you some pictures of some patient. You see here, the PASI is quite high. Usually nowadays I start apremilast on patients with a little lower PASI, something between 5 and between 15, for example. In my personal opinion, these are the perfect candidates for apremilast. But it also works in a little higher PASI patients or PASI diseases. You see here, 4 weeks later, the PASI is nicely reduced, starting at close to 20, down to 9. So this is quite a fast impact. And 16 weeks later, it's not a fully reduction, but PASI below 2. This is one of our treatment goals nowadays when we talk about absolute PASI. And you see here, it has some nice effects. There may be a little inflammation left here. And this is the same patient. We see now the legs when we start. At the beginning, before apremilast, 4 weeks later, you see here there is some inflammation left. Usually this is what we see, or typically this is what we see, that the inflammation is reduced from top to bottom. So on the legs, usually it takes a little bit longer compared to the upper part of the body. And here, 16 weeks later, a little inflammation left, but nicely reduced. So of course it also works with apremilast. But there are some unmet needs, some questions we need to ask ourselves. So can we have some positive impact on other kind or other comorbidities, for example? What about the primary loss of efficacy? How should we deal? When should we switch medication? How long should we wait until we switch a medication? Secondary loss of efficacy, again, how long do we wait when the patient's getting worse and worse until we say, okay, now it's a stop and we need to change the medication again? What about relevant itch when it's something like this is left, or some severe side effects? How should we deal if they are not that severe but have an impact on the quality of life of the patients? Reactivation of infections, it might be an issue in some patients. Adherence is also a theme. Comorbidity of plaques and treatment of moderate forms. So whenever patients do not fulfill the criteria for systemic therapies, but they have a severer form, some hard to treat areas, some genital involvement, this is something, at least in Germany, our guidelines don't give some good some recommendations in that cases. So that's why we need to have some more ideas. So it's quite simple when we talk about the normal patients. A mild form of psoriasis, we defined it, for example, in BSA, body surface area, the PASI and the DLQI below 10. This is easy. These are good candidates, for example, for a local or topical treatment. That's quite easy. For severe, moderate or severe forms, when we have an BSA or an PASI above 10 and a DLQI together with the skin inflammation above 10, this is the rule of 10. It's also moderate to severe patient, and we can recommend some systemic therapies. Doesn't matter what. But when we talk about some special manifestations, so patient have maybe in a BSA and a PASI below 10, but in DLQI above 10, because he has some infestation of some visible areas or visible body regions, for example, on the head, on the palms, or on the hands, affecting larger regions of the scalp. Of course, this has a negative impact on the quality of life if you have a severe inflammation and scaly inflammation on the scalp area. Manifestation of the genitals, manifestation of the palms, of the soles. This again has some impact, some anecholysis, so some nail involvement of psoriasis. And I don't talk about some mild forms, but some severer forms like onychodystrophia. We see some patients with just a mild form, but a severer form of nail involvement. So what should we do? Some topicals don't have any effects. I guess you had that experience also. Some itch that causes scratching. This is one of the upgrade criteria, or the presence of a single persistent plaque. So you have a plaque and you treat or you try everything what you can prescribe in topicals, but the plaque is still there. So we have the opportunity to upgrade these patients, to say, okay, this is not fulfilling the criteria for systemic in normally cases, but when they have at least one of these points, they fulfill the upgrade criteria, and we are able to prescribe also some systemics in some patients, not in all, but in some. And this why these are some cases or some pictures from my clinic with special manifestations, normally in patients who do not fulfill that criteria. Some genital involvement, of course, there are not much, but some patients who have a severe form of psoriasis in a genital area and an anal area, and the rest of the body is quite okay. Some itch, or some here just on the lower legs, here on visible areas on the scalp regions, or sometimes only on the nails, and they also want to have some kind of treatment, some kind of effective treatment. So we have not that perfect opportunities to measure when we don't ask our patients if they have some special manifestations, to measure with some kind of questionnaires, how is the impact on the quality of life, or do you have some special manifestations? For example, when we take the PASI, we have the plaque area, the severity of the plaques can we measure in a quite good way, but some other facts like what about the pain, what about the genital involvement, palmoplantar involvement, do we have a PSA? This is not covered by the PASI or by the normal questionnaires we do nowadays. Especially the DLQI, I suppose all of you use the DLQI from time to time, we do it also. But to be honest, I'm not very happy with the DLQI because it's just broad. We use it in any kind of skin manifestations, skin diseases, alopecia, acne, and so on and so on. So it's not very special for psoriasis patients. And we know very well that psoriasis patients have some special concerns, they have some special needs. And that's why what we now try to introduce in our clinical daily routine is a patient benefit index. I'm pretty sure you heard about that. It's a specialized questionnaire for patients with psoriasis, and we can do it before we start a kind of treatment, any kind of systemic treatment, and ask the patients, what are your personal treatment goals? So what do you think, what should we reach after 3 months or 6 months of treatment? And of course, this is quite different when you ask one patient to the next patient. Some patients has a severe form of itch. Some patients want to have a quick relief. Some patients want to have a normal life or normal sexual life. These are some different aspects we need to be aware. And again, we ask 3 months, 6 months later, the patients, did we reach or did we achieve that kind of treatment goals you just defined before we start the treatment? Yeah? And this is a better way, in my personal opinion, to ask specific our patients with psoriasis compared to the DLQI. It's quite nice, but I don't like it anymore. Yeah? So, but I will show you most of the data is a DLQI because it's broadly used in any kind of clinical trials and real-world data and so on and so on. So what we have here is some poster from the World Congress of Dermatology last year in Milano, and we have here some results and some information about moderate patients. So patients who do not fulfill the criteria for a severe patient or a severe form of psoriasis. It's from the MAP study, a very important study. So patients had been asked, how is the involvement of your body, how is the involvement of the psoriasis, and do you have special areas where the psoriasis is involved? And what you see here is about 160, 170 patients had a moderate form of psoriasis, and they are divided into a DLQI above 10 and a DLQI above 10 together with special manifestations. And what you see here is those patients with a higher DLQI and of course with special manifestations, they of course had some other problems related or compared to the moderate forms of psoriasis without special manifestations or with a DLQI below 10. Yeah. They have a little bit more itch, a little bit more scales, the redness is more on that patient, the flakes are more on that patients. Interestingly, pain is the same, but what I want to show you here is, yes, there are a group of patients who might need some more support even when they have a moderate form of psoriasis, and especially those who have a DLQI above 10. And now here, these are the 10 questions from the DLQI, and we have the same results or similar results when we ask our patients with a moderate form of psoriasis and in higher DLQI, what are your concerns? What is the impact on the quality of life because of your psoriasis? You see here, they are embraced. They are not that self-conscious like patients without psoriasis, of course. The itch does play a role. The pain does play a role. Or here, the influence, what kind of clothes patients can wear. This is different in patients with a higher DLQI. Of course, that's why we have that results. But again, it shows just the impact on that kind of patients, on moderate patients. This is another result from a real-life study. It's called Appreciate. It's a multinational retrospective clinical trial where we ask patients in a real-life setting who have been treated with apremilast, how was the condition before and how was the condition later on when we start with apremilast. And again, what you see here is about 400 patients or close to 500 patients are included in that retrospective trial. And the BSA, for example, in mean, so they are not that moderate. They are quite more severe, but there are some moderate patients in there. So PASI is about 12 BSA. So normally in clinical trials, the PASI is about 20 or close to 20. So these are the more moderate and severe kind of patients. The DLQI, of course, is higher than 10, the BSA of 25. Time since diagnosis, more than or close to 20 years. This is also what we see in real life. Most of the patients, it's quite late, on a late stage of disease, where they get some good medications or some nice help. Special manifestations, 2/3 of them have a scalp psoriasis or scalp involvement. 40% have a nail psoriasis, 23% have a palmoplantar psoriasis. So yes, the upgrade criteria does play a role in a real life setting. And when we look closer, when we just say or have a closer look to the upgrade criteria, it means scalp involvement, nail, palmoplantar or pruritus involvement. You see 90% of all patients have that special manifestations or some itch, important or severe forms of itch. And when we now combine it and look what is the most combination we see here, all aspects together, all four together, about 10% have a lot of special manifestations. 25% have a scalp or pruritus, about 16% only scalp and pruritus, but no palmoplantar manifestations. And the rare kind of patients or the rare disease is only a nail psoriasis. This is what the real life data have shown us. Yeah? So the message out of this chart is special manifestations are not very rare. Most of the patients had some special manifestations, and again, about half of the patients have more than one, or even scalp psoriasis is one of the most special manifestations we see. So what about the changes in a real-life setting when we start with apremilast? You see here, this is before we start with a treatment with apremilast, a genital involvement, anal involvement on the legs or here on the scalp. Most patients have some impact there. And about 6 months later, you see the number of patients who have still some involvement in that area are nicely reduced. It works quite well on the axilla region. For example, here 12% started, about 4% have only some impact after 6 months of treatment. Scalp psoriasis is quite nice reduced. The genital area, 23% started or had an involvement when they start with apremilast. About less than a half, just 6 months later, have some involvement there. So we have an impact on the most difficult to treat areas. And this is the patient who are more or less free on that kind of special manifestations after 6 months of apremilast. So 78% say we have a good improvement, a quite nice improvement on the axilla region. 1/3 of our patients said, well, my scalp psoriasis is really good reduced. We have no manifestations there on the normal body, on the back, on the front, on the legs. It also works quite nice. And again, here, genital and anal area, more than a half of the patients say, I don't have any signs or any symptoms anymore in that regions half a year later. So most of the patients have a benefit. Scalp psoriasis, I've shown you, 48% when we ask the patients say this is much better, and here in blue we have a moderately better or slightly better. So most of the patients have a profit on apremilast or in PDE4 inhibition on most aspects from psoriasis. Genital area or here pruritus, nicely reduced in half of the patients, and only 10-12% say it's not getting better or it's not become better or even a little bit worse. So the impact on psoriasis on special areas is quite nice. I want to show you also here some clinical data from my area, from my hospital. For example, here the NAPSI, a patient with a psoriasis, of course. You see here some smaller plaques. Here the nail involvement, NAPSI on 10, and 6 months later, it takes a little bit time until the nail grow out, and you see here it's quite nicely reduced. So it works also in a real-life setting, also in my clinic. These are the data from the ESTEEM trials, so it has been confirmed in real-life setting. It has been shown also in the clinical trial data. So when we start our treatment, after 24 weeks, after half a year, you can expect the maximum effect. This is related to most of the therapies, even with biologicals. Half a year later, what you see there is that what you can expect. Yeah? And this is nicely reduced, again, 60% in mean percentage change. So half of the nail involvement, or more than a half of the nail involvement, had been vanished. Palmoplantar involvement is also for patients who need to work with their hands, quite heavily impact. You see here that typical form or a form of palmoplantar psoriasis. 2 months later, this is quite a fast impact on that manifestations. You see it's completely clear. Yeah? So this is just a plaster. This is no psoriasis. So it also works very well. And again here, some patient, an Italian mother, so she was afraid of giving herself some injections, or in general some injections, even some blood drawing. It's always a heavy discussion with her. When we just want to start with orals compared to systemics, who needs some injections. You see here, that lady, it's definitely not a good candidate for a systemic therapy. Even she had no time for UV radiation. 2 weeks later, it's nicely reduced inflammation. 12 weeks later, some minor plaques are left, but also in that cases, it works quite well. So this is my first part, and I just want to summarize some of my key messages here. Patients with a moderate form of psoriasis, they really suffer and they exist, and especially those who are not a candidate for or normal candidate for systemic therapy, we need to remember that we have some upgrade criteria and that we need to use in some patients. And real-life data have shown that good efficacy also on that kind of patients. So in my personal opinion, the moderate form or the severe form with a PASI below 15, these are the most perfect patients for Tremulast. And I usually start it before I start with biologicals.